Let's get into our conversation for today. This Health Friday on the 24th day of May 2024 is the day after the 23rd. And on the 23rd of May 2024, the world was marking the International Day to End Obstetric Fistula. To tell us more about it is a consultant urogynecologist, Dr. Bob Achilla. Dr. Bob, good morning.
Good morning to you.
Welcome to Kenya's biggest conversation.
Thank you for the invite.
We call that the hot seat of the Situation Room, but we welcome you very well. Karibu sana, karibu chai. You see this? This is Majani chai. It's Kenyan tea. It's called Assis Golden Tea. Okay? So karibu sana, enjoy your Assis Premium Tea.
Asante.
City.
Yes, please.
Also welcome the guest with
the proverb for the day. The whole of this week, our proverbs have been from the Republic of Liberia. Okay? The oldest independent country on the continent. Got its independence in 1847.
And you told us who's the current president?
Well, the current president of the Republic of Liberia is called Joseph Boakai.
Joseph Boakai.
That is his name.
He's the one who beat the footballer.
Yes.
George Weah.
Yes.
Okay.
This country, up until 1979, was prosperous and it was doing well. It was one of those countries on the continent that was at the nearing the takeoff stage. They have timber, they have rubber, they have diamonds. You've heard of conflict diamonds, haven't you? Well, many of the stories of movies you've seen revolve around countries like this where the diamonds were used, it is said, to what? Finance the conflict.
Yeah.
Okay? The gentleman called Samuel Doe who chanced on this country. And for 10 years, did wonders in the most negative way possible. And all that development went underwater. The country has not survived. The country right now, from being one of the most prosperous on the continent, is one of the poorest on the planet as we speak.
And then there are some guys who came later, Kina Fode Sanko.
Fode Sanko came later, Kina Charles Taylor came later.
Charles later, Taylor, the butcher.
Those are stories for another day. If a monkey, this is a proverb, if a monkey throws down its own baby from the top of the tree, the rock below has no alternative but to burst its head.
Wow. From Liberia.
From Liberia?
Repeat one more time.
Okay, Doctor. If a monkey throws down its own baby from the top of the tree, the rock below has no alternative but to burst its head.
My own interpretation is that for every action there are consequences. Yeah. So you have to be prepared to face the consequences.
Thank you. Simple and to the point. Thank you very much.
Very good.
Yes.
Is it just you or are there many proverbs from Liberia about monkeys and bananas?
Yes, there
are many proverbs and there are even animals which exist there. There are none about zebras. But
okay. Just asking.
Is there any proverb about, rubber, diamonds, any minerals, or just animals?
Well, there are proverbs about crabs.
Okay.
There are proverbs about elephants. There are proverbs about oil. Do you want to ask any other question?
No, I think we're good.
No.
You're good?
Yeah.
You're good?
Yeah.
Okay.
Okay. So, Dr. Ari,
Yes.
yesterday was International Day to End Obstetric Fistula. What is fistula?
A fistula in broad terms is just a communication between, an abnormal communication between two organs in the body. But now specifically obstetric fistula is a complication as a result of childbirth, where now there's a hole between the bladder and the birth canal, or rarely a hole between the rectum and the birth canal, resulting in
a
leakage
hole
of urine.
between the bladder and birth canal, or rectum and birth canal hole.
Or a communication. They're completely different organs. So what happens in an obstetric fistula, the mother is in labor, but there's an obstruction. It means the labor is not progressing, so the baby's head is stuck. Maybe 2 days or even more. So there's a baby's head, and there's the mother's bone, and then there's tissue in between, which is compressed. Okay? So then maybe the blood supply is then cut off. If that happens between the mother's pubic bone and the baby's head, then the bladder is in between. And eventually the tissues there will die off and a hole might form, which is now a fistula between the bladder and the birth canal.
Right.
or much more rarely, if the baby's head is stuck and now there's the mother's tailbone and the baby's head, the blood supply is cut off, and then a hole might develop between the rectum and the vagina. And the consequence of this is now continuous leakage of urine from the bladder into the vagina, or sometimes leakage of stool and gas between the rectum and the vagina.
Is it painful when it's happening?
I mean, definitely, because the labor is not progressing and the mother is in excruciating pain.
Right.
Yeah.
So it's what would make this labor not progress?
So it means there's a disproportion between the size of the baby and the mother's pelvis, which might mean the pelvis is too small. Like, for example, maybe a very young, let's say teenage mother, or maybe the baby is a bit big, or maybe twin pregnancy, or maybe there's a fibroid or something which is preventing the baby from descending. Or sometimes there's just no disproportion, but the baby is in a funny position. Let's say the head is just a little bit tilted, which means now the diameters are not presenting in a good way for the labor to progress.
Okay.
Yeah.
So there's something that prohibits this labor from progressing.
Exactly.
And we're saying as a result of that, then a fistula forms, right?
Exactly.
So
yes.
the woman could be delivered of her baby, right? But the resultant situation is that a fistula will form. Are we saying that happens?
Yeah, but you know, this is
After, or it's in the process of this happening?
No, it's not an immediate thing.
It's later.
It will happen after a couple of days.
Okay.
But you see, this is just one of the many things which is happening to this woman.
Yes.
Because, like, you know, in Kenya, there's a high maternal mortality rate.
Yes.
Above the global, maybe, average. And one of the causes of maternal death actually is this thing called obstructed labor. Because if the labor is not progressing and the woman is in labor for days and days, she gets dehydrated.
Yeah.
She's susceptible to getting infections.
Yeah.
She might get severe bleeding as a result of the uterus rupture. You know, the uterus is contracting very powerfully, which is a natural process to deliver the baby.
Yeah.
But now the baby is stuck.
Yeah.
So many of these women actually end up dying from this obstructed labor.
Okay.
But the ones who survive can now have consequences such as a fistula.
Okay.
And then also, almost always the baby dies in this kind of a situation. Many mothers die, but the ones who survive, one of the consequences can be a fistula.
Okay.
Yeah.
One of the things you talked about was, younger women. So if we just look at the process of development, so in younger girls, obviously, when you look at as you're growing older, things like your hips then and your pelvic area will then widen as you grow older.
Yeah, with time.
You get into puberty, right? So then it is assumed then that your body is then preparing for one of those processes, one of them being childbirth. So if a pregnancy occurs in a younger girl, in a younger woman, then this process of the widening of the pelvic area has not happened.
True.
So would you say then that a lot of those who suffer fistula are in the younger age demographic?
Usually we can talk about maybe risk factors for fistula formation, which is a much more broader kind of thinking. And one of the risk factors definitely is maybe early or underage pregnancy. But there can be many other factors which can prevent the progress of labor and result in an obstruction and a fistula. But maybe just to go back to this situation which I was trying to describe, you know, when the baby's head is stuck in the pelvis for a long time, apart from fistula formation, there can be many other consequences because it's also compressing on other structures. Like, for example, the nerves in the pelvis. And some of these women sometimes can end up with what is called a foot drop or problems with walking. Because they are also leaking urine. Sometimes they are afraid to drink a lot. And they can end up getting dehydrated, infections. And then, of course, because of that smell, there's like social isolation.
Of course.
They might shrivel up and maybe go to some corner and maybe develop like contractures. Then, of course, to the society, there's a lot of stigma. Because, you know, for a fistula, there's continuous leakage of urine. Then this woman, you remember, she has lost a child.
Yeah.
She's a survivor of maternal mortality, just a narrow escape. Frequently, the husbands will leave them. Society will shun them. So you can imagine in terms of the psychological impact to these women. And then sometimes they can even get, like I said, infections or even kidney damage. So it's a much broader thing, apart from just the formation of the fistula.
Sure.
How common is it in Kenya?
Actually, fistula is one of the causes of urine incontinence, but fairly common in Kenya, because actually by estimates by WHO, maybe globally, almost like 100,000 new cases of fistula, and then they estimate that maybe there are like 2 million cases of fistula.
100,000 new
not
cases?
Not in Kenya, maybe like
worldwide.
Yeah, because fistula is mainly in poor countries. Because you can imagine, why is this woman laboring for 2 or 3 days without an intervention? Doesn't happen.
Not in hospital.
It doesn't happen in developed countries. So these are problem of poor countries. And then so maybe like in sub-Saharan Africa and maybe some Asian countries, maybe like a total of around 2 million cases of fistula in terms of prevalence. Yeah.
Okay. When does one then begin to experience the symptoms of fistula? Because of course you've gone through this traumatic experience, birth, baby dies, and then all of these things happen. When do you start to experience these symptoms that you speak of, incontinence, etc.? Or is it immediate?
It's not immediate because now the tissues will die off and slouch off. So usually within days to weeks, the woman will now complain of continuous leakage of urine. Within days.
Okay.
Yeah.
How is this fixed, if it's fixed? Is it possible to cure a woman of fistula or to repair fistula?
So the management of fistula is actually surgical because you have said the definition is that it's a hole, an abnormal communication. So this has to be repaired surgically. Although this is like a narrow view of the situation, because as surgeons, of course, we can fix the hole, but now that does not restore other issues around the woman. The psychological situation, the emotional trauma, the loss of livelihood, the stigma and other things. But in brief, for us as surgeons, it's a procedure which can be done in terms of repairing this abnormal communication.
When you celebrate or you have an international day that seeks to highlight the process of trying to put an end to this problem, what exactly is the day about? What exactly is being talked about? What is it that people need to understand?
Yeah, it's an important question, City, because many people don't know about fistula. And like some of the questions I'm trying to answer might create more awareness about this situation. Because it's an issue of quality of life and loss of dignity for women. And by highlighting the situation, it might bring it to the fore and encourage people to understand what it is and encourage mobilization of either resources or action to do two things. One is treatment of fistula, because there's a huge number of women with fistula who are untreated. And as I said, every year the number keeps on increasing. But secondly also is in terms of prevention, because unlike other diseases, obstetric fistula is an entirely preventable condition. Because like I said, for example, a developed country, they hardly ever talk about obstetric fistula. It's a problem of poor countries. The woman is laboring, the labor is not progressing, so there are issues which are preventing this woman from going to the hospital, which might mean it might be from the side of the patient. For example, either they are illiterate, they don't have much awareness in terms of the danger of being in labor for too long, or maybe the position of the woman in society is such that they cannot make the decision that now I need to go to hospital. They have to wait maybe for an older male relative to come and make that decision for them.
I'm sorry. Please explain.
What
does that mean?
Like for example, there was a doctor was telling me that they work in Marsabit, or one of those northern
counties.
And then the other woman in labor, and everybody has made a decision that you need to go for cesarean section. But the woman cannot sign the consent because she says, I need to wait for my uncle to come and make the final decision. Of course, there's a lot of delay in terms of appropriate action. But it happens quite a lot in many of our societies where maybe because of the position of the woman, decisions have to be made by maybe older male relatives.
Yeah.
But there can be also other issues can be contributing to why this woman is not going to hospital, which might also be something like finance.
Sure.
Because hospitals maybe might have some charge.
Yeah.
Even if it's a very small amount of money, maybe 200 shillings or whatever amount, this can be a great impediment to the woman progressing to go to hospital. There are many other issues also, maybe like infrastructure. There have been floods.
Yep.
And maybe the bridge has been swept away.
Yep.
And there's no road to the hospital, or the hospital is very, very far away, 200 kilometers away, and there's no means of transport. It's a complicated situation in terms of why we have this issue. But of course, the underlying thing is just maybe lack of adequate education and development of a country, healthcare infrastructure, general infrastructure, and things like that. On the other side, of course, is the hospital. Do we have adequate and well-trained personnel? Because the woman could do everything, make a decision, I need to go to hospital, my labor is taking too long, and they're here, and there's nobody in the hospital. Maybe there's a doctor's strike or something is happening. Or the people who are there manning the hospital are not adequately trained to be able to identify that maybe now this patient needs an intervention immediately.
Okay.
Could
we look, get into medical a little bit more here? And if you talk about interventions that are needed during the childbirth process, that if they are not administered, then that we could get into a tricky situation. What would some of those things be? What would be a situation where a woman has labored for too long and then it's causing an issue that there has been no intervention for? What are some of those?
In fact, the most powerful intervention to prevent fistula is timely intervention by cesarean section.
So what would be happening that you would need to make a decision to go for a cesarean section if she had started progressing naturally? And then you say, okay, hold on, everybody, we need to cut.
In labor, we are monitoring two things. The dilatation of the cervix, because the cervix will be closed, but eventually it will open up until what we usually say is 10 centimeters. Because the uterus is contracting. It's a natural process and it's ongoing. So we are monitoring the dilatation of the cervix, but we're also monitoring the descent of the baby through the birth canal.
Yeah.
So if the cervix is not opening up and you've given adequate time, and
what is adequate time?
Usually there are some cutoffs, but they're not so strict. You have to make a judgment as a clinician.
As you go along.
So you usually monitor the patient, and we have tools which we use like the pathograph and ETC. And then maybe there can be a line beyond which, if the labor is progressing beyond it, you have to make a decision as to do I give more time or not. Also depending on your situation. If you're able to monitor and you're sure the mother is okay and the baby is okay, you can always try to give more time. But if there isn't adequate descent and dilatation of the cervix despite giving adequate time, then you have to make a decision for another mode of delivery. The problem sometimes, of course, is that there can be some thinking that vaginal birth is the best, which I might agree with, of course, to a great extent, but not under all circumstances. Many times a cesarean section can be a very good intervention to prevent complications. But to make it simpler, in a hospital situation, it's unlikely that you can develop a fistula, because an intervention, of course, will always be instituted. Fistulas are mainly occurring in patients who are laboring out of hospital for many, many hours to days, and eventually could end up dying or developing other severe complications.
Are you saying that we don't find women in labor in hospitals for many, many hours, 48 hours and even beyond?
No, it happens, but it's a bit unlikely that you can develop a fistula if you're in hospital, because at some point somebody will intervene.
Okay, now, when we talk about adequate medical personnel being available, now we know that if we look at the WHO threshold for the ratio of doctors to patients that we should have, we don't meet that cutoff point. Is it within the realms of possibility that other medical personnel can be trained, to diagnose and understand the situation so that the person is probably moved from where they are to a place where appropriate care can be taken? But even more so, when you talk about traditional birth attendants, because we still have a very large number of people in this country who will go to a traditional birth attendant because that is the person who is known to be able to handle such matters. Are there situations where such people can be trained to simply understand that this thing is beyond us and it is necessary for us to take the next step and get this person to a health facility where they can be attended to appropriately?
Yeah, it's a city. I like your question, but it's also a bit complicated. But one thing you have to know is that the childbirth process itself is the tail end. This process begins when the woman maybe is initially planning to get pregnant, which means we want pregnancies to be planned. Okay? Which means also there's an aspect about contraception. Which also means that there are certain categories of women that maybe should delay getting pregnant. Like, for example, you've talked about if you are still maybe like a teenager or etc. This is not an appropriate time for you to get pregnant. So before you get to the delivery and labor process and etc., we need to go much, much further in terms of, is a pregnancy planned? Okay, are you ready for pregnancy? Which means maybe might need to be on some form of contraception or something like that. And then once you're pregnant, it's very important that you have to attend the antenatal clinic. There has to be education to women that you need to be seen in clinic while you're pregnant, because many of the issues which we encounter in the delivery room, which can lead to complications, could have been easily identified or even resolved while the woman was pregnant. So, for example, common scenario, somebody is coming in labor and the baby is in a wrong position, what is called like a breech, buttocks first. And then you're discovering this when the woman is almost delivering, and there's a panic and everybody's running around. But if you had known it 3 weeks earlier, then you could have advised maybe even for a planned cesarean section. Or sometimes a woman comes in and she's in labor and she has twins and did not know.
No one knew.
No one knew. Yeah. So you see, you can end up with serious complications at the time of delivery. And yet maybe some intervention could have been done much, much earlier if we knew. And also maybe sometimes there are some medical conditions which can lead to issues. For example, if you have diabetes and it's poorly controlled, big baby. So just attending clinic and following the advice, doing at least some few ultrasounds can prevent a lot of issues which sometimes we encounter in the delivery room. Now, coming to your question in terms of can other healthcare cadres help in bridging the gap in terms of the medical workforce. I entirely agree with that, because we don't have enough obstetricians, and it's not practical in any country that every delivery has to be attended to by an obstetrician. In fact, even in developed countries like even the UK and etc., it's mainly midwives who are conducting deliveries, because you can train more midwives and standardize the care of women. The most important thing is that it has to be a trained healthcare professional. The problem in Kenya is that many deliveries are not attended to by trained healthcare professionals. But of course, it's up to the various cadres to agree amongst themselves in terms of the scope of what you should be able to do.
Dr. Bob Achilla is a consultant urogynecologist. He's here today telling us all about obstetric fistulas. Yesterday was the International Day to End Obstetric Fistulas. But there was a urogynecologist. Why not just a gynecologist?
Yeah, so by urogynecologist, it means at base I'm trained as a gynecologist. But then I've undergone further training in women's pelvic floor issues, which include bladder problems or problems with bowel, sexual dysfunction, and something called pelvic organ prolapse. So it's just some subspecialty within gynecology.
I see.
Which includes dealing with issues like even fistula.
Okay.
And how many people have this training that you have in this country?
Well, I was the first to be registered. I've not checked the register since, but there are many people training in this subspecialty now.
They're in the process of training.
Probably there might be others, and it's becoming now something that many people want to do.
Okay.
Yeah.
100,000 community health workers, that's what they're called, Abby?
community health promoters.
Community health promoters were, contracted. I'll use the word contracted by government just not too many months ago. So that meant that they were going into different parts of the country, essentially within communities, to give the very basic in terms of information when it comes to healthcare. From what you're saying, when a woman goes into labor, there's little bits of information that you should have in order for this process to be a little bit easier.
Okay.
Now, what you're also saying is that in the case of the formation of fistula, that it is 100% preventable, right?
Indeed, yeah.
That if you were in a medical facility at the time of childbirth, that if there was something that was obstructing this proper delivery, that could be sorted out. If there was a reason why there's distress in a medical facility, that can be sorted out. It's a matter of information. Would you say that these community health promoters, having had this basic information, that this is one of the things that probably could be front and center of what they promote in community, if it's 100% preventable?
I guess this is one of their mandate and one of their roles, to educate the public about seeking healthcare, because there can be a problem in terms of health-seeking behavior. So, for example, if you have a severe headache and you're at home for 2 weeks, it's until that point when you make a decision that I need to go to hospital that an intervention can be made. So, labor many times goes on very well, but there needs to be an understanding also that if the labor is not progressing or laboring at home, can have serious consequences for you. So I think maybe education is very, very important for people to be aware that there can be serious complications which can result as a result of obstructed labor, including maternal death of the baby, and serious issues such as fistula. But of course, I think maybe I can re-emphasize the point that labor is a tail end of the process.
Yeah.
There is a whole period in which you are pregnant, at which you need to be seen in hospital
At least
a few times. Okay, usually maybe they say up to 8 times now.
Wow.
but I think even if you have to go once, it's much better than not going at all. Yeah, because so many things can be picked up, including even your previous history.
Sure.
And some interventions can be put in place much, much earlier instead of waiting for labor and then trying to do things at the last minute when maybe it's not possible to correct some of these things.
Okay.
Yeah.
So there are some issues then. So there'll be several reasons why this woman who's pregnant will not go for antenatal care. One of them may be cultural. They're like, okay, apana, sisi, hospitali, those ones. Second one would be the issue of cost. So they're thinking, every time I go here, this is a cost, and I want to minimize how much I spend. And maybe I'll just go in the final days of labor. Another one will be access. Distance from said woman to the nearest health facility that can offer this kind of care. Now, I'm sure you'll agree with me that the third one has higher risk of ending up with this kind of complications at childbirth.
Yes.
Now, even with community health promoters being deployed across the country, if there's no health facility that's about 10 kilometers radius to you, you are still at risk. So how do we address these issues? How else can we ensure that these women are taken care of? Which I want to go back into CT's question. Traditional birth attendants. I know your professionals, your profession, the obstetricians and gynecologists I have sat in a forum where many of you have actually said, no, we should discourage this whole thing of saying anti-traditional birth attendants. No. But don't you think they have a sense? They have a place here somewhere?
Yeah, you see, now this is where some controversy starts. Where there's maybe depending on the country where you are.
Yeah.
People believe that it doesn't matter too much who's taking care of the patient. So long as something is done, we are lowering our standards. Because as much as we are a poor country, a healthy population can be a very big booster to development. Pregnant woman is very complicated. Labor is a very complicated process. So I don't know how low we want to go in terms of who will be taking care of our mothers when they are pregnant and when they are laboring.
Maybe not low. if you can consider encouraging the traditional birth attendants to be in an association of some sort where they get some regular training, where they also know at this particular point, reach out to a health professional. At this particular point, consult here. At this particular point, you can do 1, 2, 3 things. If you can offer them some, like you said, some level of training, but you give it some bit of comfort.
Yeah, we can't dismiss them completely, but now this level of training is now what becomes controversial. Because the more you train, then the more you're turning into a midwife, the more you're turning into a nurse, the more you're turning into a doctor.
Yep.
But usually it's said that maybe in poor countries they want maybe solutions for poor people.
You see,
but there's that minimum standard of care to any human being. The way you manage a patient with hypertension in Kenya should be the same as in the US. It's not like I know you're just in Kenya and you have hypertension, because the consequences can be the same regardless of where you are in the world. If you get a stroke or kidney damage or other things, it's much worse for the country than maybe trying to put in some small intervention which seems like a stopgap measure but can be worse in the long run.
What you're saying, I understand, and I understand it very well, because by the time somebody becomes a medical practitioner, the training you go to and the understanding you have, there is so much more you know. And because of that, you feel someone who doesn't have this knowledge may probably cause more harm than good in the long run. And yet they mean well. But this is a debate that's going to go on for a very, very long time, because there is a demand issue here. There are people who will still go to these traditional birth attendants. And the reason is because the birth attendant has a track record of success.
Yep.
Okay?
And in many cases, the only the closest available
Yes.
help.
Yes. He talked about research. No, he didn't. I'm talking about research. Research actually has shown that when it comes to reducing mortality, training traditional birth attendants does not help reduce mortality at childbirth. And when compared to people who have been actually medically trained, the mortality rate is reduced significantly when you have somebody who's medically trained attending to a mother who's giving birth. But that one research has shown. It's not something that is an ifs and buts. But when you're talking about 28% onwards to around 35% of people in certain regions, for instance in this country, still going to traditional birth attendants, despite the proliferation of healthcare facilities and the increase of the number of people who can provide what you call healthcare because they've been trained, it is not that cadre of health personnel cannot be ignored. You see, even the issue of community health workers, I know we've given a funky new name. I'm not going to use that name. I'm going to call them
promoters.
Yes,
Yes,
promoters. Yes,
they promote.
You see, when you're talking about promotive or you're talking about preventative and promotive healthcare, it's very basic. And yes, again here, research has shown that in certain instances, in certain diseases, you're talking about malaria, you're talking about diarrhea, they can be used extremely effectively. Okay? But what Dr. says, which is true, is in a rural setting, these people then become doctors.
They go beyond the scope.
Yes, and that is where the problem arises. Because people go to them for specific things and they even know what it is that they should do. But because they're the only ones available, sooner or later, they start taking up roles.
But you see, that's the thing, City.
Yes.
You see, it's a system issue. You've sent a community health promoter to a certain village, right? And yet this village doesn't have a functional health facility.
Or one nearby.
Yes. So what happens is that the people know this to be the health person.
Yes,
They're
they
called
do.
health. So the people will go to the health officer, and they don't know you're a community health promoter. You just wear a white coat.
Health.
Yes, and you came the other day with this thing and you pimmered my pressure,
Eric,
and you
even
answered
people,
that
even people who sell smokies wear white in yours.
Yeah, but they don't pimmer your pressure and your temperature. You know. So when they start pimmering your pressure and your temperature, and they're talking about health and they're telling you eat this and eat the other because of your health, then they become the health experts. And if there's no other health expert or health facility nearby, then the people just know that this is a person, this is a government person, so this is a person we go to. And then the person may be meaning well. They want to offer you better service. But if they know that they're sending you some 100 kilometers away to the next health facility, and they can look at you and they know who you, after 50 kilometers, how do we go there?
You have a very valid point. You see, I raise this because I have been a champion for community health promoters. It's an agenda I've pushed for the longest time. So when they came into being, I said, at last. But the limitations that we have to be pointed out so that they are taken care of.
Yeah. So maybe the other thing, the other way to look at it maybe is they might be better than nothing, definitely.
Yeah.
But there has to be like a long-term overall plan. You know what sometimes happens is you start a stopgap measure, then it becomes permanent. Now this becomes like what we think is the best standard of care. If there's an overall ultimate goal in terms of how we want our healthcare infrastructure and personnel to be, but then this is how we are beginning and eventually build capacity, then it makes sense. But the problem that sometimes we have is that somebody comes up with an idea and then it becomes like a permanent solution. But this is not the...
It is not the ideal.
Yeah,
but
you see, Dr.
It has to be very clear to us that this is not the ideal, but in the meantime, this is what we are doing.
There's a bigger problem here. The way people who have the magnificent training like yourself who are doctors, I am aware that we've moved from the time when medical doctors believed that clinical officers, nurses were adjuncts, meaning they were not considered as separate professionals within this particular sphere, but they were sort of like a lower cadre health person. Now, the thinking that only doctors can actually provide the care is where we need to move from and embrace those who can do certain things and say, this one they can do. I know this because I have lived a situation where even the small matter of counting drugs so that you can package it was an issue because you're not trained to count. You've already gone to school, surely.
So, Siti, maybe the other thing is this.
Yes.
What we want at those lower levels
Yes.
is probably not training in terms of intervention, but training in terms of recognition
Yes.
of an issue and referral.
Exactly.
Yeah.
Yes.
Because I'm looking at a situation that where we continue to flirt with danger here, and we because I cannot imagine what a woman would be going through with an issue of fistula. I cannot imagine minute to minute suffering for 24 hours for however long until the issue is taken care of. It must be life altering in terms of, and then just the danger of infection and then having to go in for treating an infection over and over and over again, because that's what you deal with, is it not? Exactly. You're dealing with this danger of infection every minute that you have fistula. So if we look at it like that and say that one woman suffering fistula is too many a woman for us not to do something about this recognition of a danger. So can people be trained to say, okay, look, when we see that there's a possibility of something happening, then can we refer quickly? And then the onus then lies on jurisdictions to say, look, if we don't have a functioning medical facility whereby this danger then lies threatening, then we must do something about it to make sure, especially because we've already established that this thing is 100% preventable. 100%. Not 50%, not 25. It's 100% preventable if this woman at the time of labor is in a medical facility whereby any kind of obstruction then can be prevented or intervention can be made. You know, I think we still kind of glossing over it like, all right, well, if we have, then no. Because if we look at what a woman goes through who has fistula, that should be enough for us to say, no, guys, we're playing Russian roulette with this thing. Let us make sure that we do something about it.
It's very depressing. Like sometimes when you organize for fistula camps, you find, let's say, a woman who's 58 years old coming in for repair of fistula.
And she's had it for...
And then she got it when she was like maybe 18 years old. So you can imagine, the quality of life that she has been leading for all that time. It's unbelievable. It's completely devastating. So there are usually two things. One is treatment of the fistula, because there's a huge number of women with fistula. And sometimes a very long waiting time before the repair. So there needs to be investment in terms of capacity building and training for people to manage this kind of women and alleviate their suffering and reintegrate them into society.
Right.
But also now there's the other aspect of prevention, which from this discussion is coming out as something which is a bit complicated and multifaceted. Do we have the required workforce? Do we need to integrate other lower cadres? This is a debate, of course, which needs to go on. There is the contribution of government, of course, in terms of infrastructure, both in terms of health, but also other kinds of infrastructure, like access roads.
Yes.
And then also investment in education, because illiteracy is a very big risk factor.
Yeah.
For complications.
And even culture and tradition, where you have to wait for your senior uncle to say you should go for.
Of course, also eliminating some of these cultural beliefs and practices around labor and delivery, because in many communities, if you have a cesarean section, then they consider this to be a very, very bad outcome. But in many circumstances, cesarean section is a very good intervention if the decision is made by appropriately trained persons. And then, of course, also eliminating things like early marriages and early childbirth, access to contraception. So the prevention part is complicated, and many people are trying to do something about it. But what we know from many countries is that once there's improvement in terms of the socioeconomic situation in a country, then things like fistula just usually disappear on their own. So it's mainly a problem of poor countries.
It's a poverty issue.
It's a poverty issue, yeah.
Because even when you say poverty, it's not necessarily at the far-flung areas. I am sure, Dr. You've
Even
come
within
across...
Nairobi and the slums. And
that's what I was about to say. That people who did not even give birth at home, but they went to some local, what they consider to be a health facility, and they ended up there, but they found somebody who's completely inexperienced to handle what they were dealing with, and they ended up here. But as far as they know, they went to a hospital in Nairobi, right? In a slum area. But they found somebody who is a quack, and what kind of intervention they got was just the wrong intervention. They end up with fistula and other complications. So regulation is also a big issue here in terms of just KMPDC making sure that we have the right facilities in all these counties, in all these urban areas where poor people live, and the next and nearest most affordable health facility is just some random Joe who opened up a shop and wrote hospital.
True.
But Dr. we thank you very much for joining us today. We'll continue these conversations in future.
Okay.
Dr. Bob Achilla is a consultant urogynecologist. He was here this morning to talk to us about the International Day to End Obstetric Fistula, which was celebrated yesterday worldwide.
This is the Situation Room, the only way to start your day.